Dr. Jackson, in your clinical practice, or hearing from your colleagues, or hearing from internists that you collaborate with, in terms of identifying what barriers exist to measurement-based care, off the top of your head, are there any kind of barriers that seem to be more common across clinicians, and you know, does it differ for psychiatrists or folks in primary care? And what is some of the advice that you've been able to give clinicians over time to help kind of circumvent or tackle these barriers? Any thoughts on this?
Wonderful question, George. And I think that the truth is, historically, one of the barriers has been, I just don't have enough time. There's been a difference in psychiatric practice and primary care practice historically, where psychiatrists traditionally saw fewer patients during the day with longer series of sessions, and primary care, we're seeing more patients per day with shorter sessions. I think those two styles of practice have converged somewhat, where you guys in psychiatry are doing a whole lot of medication checks and follow-ups, and you're probably seeing more patients during the day, whereas we, with the advent of value-based care, are sometimes spending more time with the patients because the reimbursement model has changed and form does follow finance. And so we're doing more case management in the office now than we used to do. So it's not just about, let's see this X number of patients with sinusitis, et cetera. And so we do have more time built in and baked into the primary care model. I think still my colleagues are going to say, boy, I just don't have time for this, don't have time for this. As long as there's EHR compatibility, where a screener or a tool or a scale can go into the EHR. It's done by the patients, typically before the clinician enters the room. This doesn't interrupt the workflow of the practitioner and tends to be very effective. With due respect to QIDS, we've sort of adopted PHQ-2 and PHQ-9, you know, Kurt Krunke helped to sort of raise the profile of metric-based care in primary care utilizing PHQ-9, and we've found it to be actually very beneficial. STAR-D, Monte Carlo was a watershed moment for me in my career when to switch metaphor, sort of the light came on, and I recognized that I was doing affective disorder in primary care as sort of a qualitative enterprise. And I wasn't doing any other aspect of my practice that way. I didn't treat hypertension qualitatively. Oh, your face looks red, you need more lisinopril. I was measuring blood pressure. I had a sphygmomanometer. And I began to see metric-based care as sort of the affectometer, a way to understand patients a bit better, to supplement my sort of pattern recognition and qualitative questions. If practitioners find that they're gaining that type of value, they'll make time and they'll alter the workflow to get the information. If it's not useful and if it doesn't drive decision making, then they're going to say, oh, this is one more box I have to check on the EHR. And so I think your point is well taken. Metric-based care is not algorithmic-driven care, but they do tend to go hand in hand. If there are critical decision points associated with different metrics, then it becomes important, then I gain value from it. And what I tell my primary care colleagues is, use it for a week and see how it does for you, but I think you'll find it's actually a time consolidator, because I very quickly can cone down to the types of symptoms and the depth of severity and which patients I need to spend more time with based on some simple metrics such as GAD-7, PHQ-9, a screen for bipolar disorder, a screen for ADHD, or other screens and symptom raters within the sort of mental health suite.